90% of patients will have H. pylori positive. Majority of colonized people remain healthy and asymptomatic. Only a minority develop clinical disease. And in 90% of duodenal ulcer patients, H. pylori will be found positive as well. In 70% of gastric ulcer patients, you may find H. pylori is positive. So this depends upon the host factor as well as bacterial related. So immune response, smoking and stress, they may cause more of the ulcer formation. So it is H. pylori is able to facilitate gastric residence, induce mucosal injury and avoid host defense. So they survive by this way. It is motile and burrows and lives beneath the mucus layer. So they remain the mucus layer. They are flagellate and motile. They produce urease. This is their typical feature, which will decompose the urea and produce ammonia. So by way of urea, they decompose or metabolize the urea, and it will form into ammonia. So this is also for diagnosis we'll later discuss. So by way of their proteins on the H. pylori, they secrete, they will increase the cell permeability, though they are able to penetrate through the cell. And efflux of micronutrients, their induction of apoptosis, that means cell death. So they'll induce cell death in the gastric and duodenal lining epithelium. So in majority of patients, it will cause mild pancreatitis only. In others, they will cause antral predominant pattern of gastritis. So this is here by duodenal ulcer, there is antral predominant gastritis, while in gastric ulcer there is non-atrophic pangastritis and corpus predominant atrophic gastritis. So in gastric you can see there is chances of gastric ulcer more. Cancer is more. Another factor apart from H. pylori, it is NSAIDs, that is non-steroidal anti-inflammatory drugs, and aspirin. Previously aspirin we were using very much because other NSAIDs were not available. So they cause mucosal injury by way of their side effect, and chances of ulceration was more in such patients. So if patient is more than 60 years old and has a previous history of ulcer, stomach ulcer or duodenal ulcer, when take the aspirin or NSAIDs, then chances are they will have again recurrence of the ulceration. So if patient is taking high dose of NSAIDs, or it is taking a high risk NSAID like indomethacin, ketoprofen, piroxicam, they are causing more of ulceration in the stomach and duodenum. So newer COX-2 inhibitors have been developed which are gastric friendly. So if COX-2 we are prescribing to patient, there are less chances of developing duodenal ulcer or gastric ulcer. So if person is not tolerating this newer older one, then we can prescribe them COX-2 inhibitors, drug like nimesulide and other drugs. So this is the theoretically how the ulcer develop. So ulceration and healing process, how it works, it is there. You can see the endothelial cell, when there is stasis, it will cause ischemia and there is ulcer formation, or direct toxicity by ion trapping. Epithelial effect, when there is HCl secretion is more and mucin secretion is less, and less of HCO3 secretion, patient may go into ulcer formation. So how to prescribe NSAIDs? So least dose and gastric friendly NSAID should be prescribed to the persons. Avoid NSAID in the warfarin because it will prolong the action of warfarin also. So more chances of bleeding. Allow 2 to 3 weeks to assess the efficacy of the NSAID. If it is not responding, then you can shift to another NSAID. Always give proton pump inhibitor. Nowadays, proton pump inhibitors, particularly omeprazole and pantoprazole, they are quite cheaper. Government is giving free drugs to the patients. So anytime you prescribe these NSAID, give protective therapy also. Because we are giving NSAID nowadays for 1 week, at the most 2 weeks. We don't prescribe even severe osteoarthritis. Previously, we were using continuous 1 year, 2 years NSAIDs, and they were causing more problem. Nowadays, definite treatment of osteoarthritis has come. That is hip replacement or knee replacement. So we are not prescribing much of the NSAID, only when patient has undergone some acute trauma or some surgery for a limited period, 1 to 2 weeks only, and then SOS use only. So always give PPIs or H2 receptor blockers along with the NSAID. So they should not be prescribed for longer time, and never prescribe more than one NSAID at a time. Smoking. Again, there are multiple factors. Smoking will promote the ulcer formation. So any person who is smoker, less of bicarbonate secretion, mucus secretion is less in such persons. So they are more prone to develop gastric and duodenal ulcers. So one should avoid smoking. Hypergastриnemia states. So this is about Zollinger-Ellison syndrome. This is due to gastrin secretion, hypergastrin secretion. So hypergastриnemia is there. So there may be a tumor or simply cell hyperplasia to secrete more of the gastrin. So more gastrin secretion means more acid formation. So this will cause ulcer formation. Why this syndrome is important? Because in few persons, despite giving PPI for prolonged periods, say 1 year, 2 years, still when they stop it, they will develop ulcer again. There will be symptoms. Secondly, you have to prescribe sometime twice a day. Most of the PPIs we are using once a day, and it's enough for 99% of patients. Only 1% of patients, or less than 1%, who are having JD syndrome or hypergastриnemia, they will not respond to single dose therapy. So double dose therapy has to be given. So this is rare, and 0.1% of cases of duodenal ulcers are due to this state, JD, and that both sexes are commonly involved. It is a part of MES. In few patients, it is part of MEN syndrome, that is multiple endocrine neoplasia. So most commonly it is found in the pancreas as well as in a part of duodenum which is near to the pancreas. So commonest location is pancreas and duodenum. Other sites are also seen rarely. So marked hyperactivity leading to severe peptic ulcer disease. It is caused by gastrin producing endocrine tumor. Multiple ulcers are found. Once you go for endoscopy, most of the time we find single ulcer only. But when you find multiple ulcers, think of Zollinger-Ellison syndrome. So you can go for the gastrin level in the serum, and for high fasting gastrin serum level more than 10 times of the normal level, and usually it is more than 1000 picogram per ml. And you can go for secretin testing if you suspect JD syndrome. So injection of secretin 1 unit per kg, it will increase the serum gastrin level by 50% of the baseline, and or 120 picogram per ml or greater of the gastrin level. So JD syndrome, it will cause, because the gastrin level is very high, 10 folds the normal. So acid production is very severe. It may regurgitate to esophagus also, and upper small intestine. So they may reduce the luminal pH to 2 or less. 2 or less means very highly acidic. Usually in the upper intestine there's alkaline pH. In the stomach it is acidic pH, while in the small intestine it is alkaline. When this acidity is increased in the upper part of the intestine, so as I told you, symptomatic, this may cause pancreatic lipase inactivation due to high acid environment, because in such patients so much of acid is produced that it may destroy the pancreatic lipase, as well as bile acids are precipitated due to high acidic environment because of high acid output. So patient will complain of diarrhea and steatorrhea. So a patient with burning epigastrium of prolonged duration, 1 year, 2 years, 3 years, not responding to PPI, requiring double dose, still they are complaining also diarrhea and steatorrhea. Your mind should click to the possibility of JD syndrome, Zollinger-Ellison syndrome. So around 90% tumor occur in the pancreatic head or proximal duodenal wall. At least half are multiple, and tumor size can vary from 1 millimeter to 20 centimeters. So big tumor may be found. This gastrinoma may be multiple also. Half to two-thirds and 50 to 66% of patients may this gastrinoma are usually malignant, but they are slow growing and they are part of multiple endocrine neoplasia in 60% of patients, 20 to 60%. So always search for the MEN, other features of other associated pathologies with the diseases associated with MEN. So severe and often multiple peptic ulcers are found in the unusual sites. So not only multiple, but not at one side, but multiple sites, and abnormal sites like post-bulbar duodenum, jejunum, esophagus, and they have got poor response to standard ulcer therapy, and rate of complication in such patients due to high acid output, it is very high. So more chances of bleeding and perforation. So any patient with these complications, search for Zollinger-Ellison syndrome. So how to diagnose? This just for outline. At this stage, imaging techniques like CT, MRI, isotope scanning, and endoscopic ultrasonography, these all may add into diagnosis of such patients. So radio-labeled somatostatin receptor scintigraphy and 68 gallium dotatate PET scan, they are useful to locate the gastrinoma. So synthetic somatostatin analog octreotide, when given subcutaneously, it will reduce gastric secretion, and they are useful for treatment as well as for diagnosis sometimes. Overall survival is 5-year survival is 60 to 75%, because most of the patients are malignant. So all patients with JD syndrome should undergo screening for MEN1. So other causes may be other infections, drugs and toxins, not only NSAID but other drugs and toxins and miscellaneous. Malignant ulcer disease you will read in your surgical this one. Systemic inflammatory disease disorders, they are also causing sometimes ulcer formation, particularly Crohn's disease, ulcerative inflammation, various vasculitis like Beckett's disease in the mouth you can see. So ulceration in GI due to vasculitis, Churg-Strauss syndrome, these are very rare causes. Ischemia, so gastric or duodenal vascular ischemia will lead to this multiple ulcer problem, typically in elderly. Superior mesenteric artery thrombosis, so it will lead to ischemia and they'll ulcerate at that place and they may bleed profusely and they may die. Sometimes thrombosis there. These ischemic ulcers tend to heal slowly and there is chances of recurrence. So upper mesenteric ischemia causes, this is typical history for mesenteric artery thrombosis or ischemia, that there is upper abdominal pain which will be elicited by meal or physical activity. So any elderly patient coming to you with severe pain abdomen and he gives history that immediately after taking some food, because his stomach is coming down to and his intestine are coming into action to digest that food, they'll have less blood supply at that time and they'll start feeling pain there. And particularly if there is profuse bleeding per rectum or hematemesis, then be alert. That patient is not simple and you try to manage it in hospital. And these patients, because pain is there, they will avoid the food and it will lead to chronically anorexia and weight loss. So such patients should be evaluated by angiography, CT angiography. Stress and other ulcers, we know in ICU or during hospitalization, there is stress to the patient in form of infections and septicemia. This stress will produce more ulceration in the stomach and duodenum. Anastomotic, leave it. Clinical feature you all know. Common presentation is epigastric pain and discomfort precipitated by food, nausea and vomiting, weight loss, hematemesis, sometimes melena. So typical pattern in duodenal ulcer is usually pain occur after 90 minutes, 1.5 hours to 3 hours later to food. So patient is taking food, gone for sleeping, and suddenly in 12 o'clock midnight he'll wake up and say, I have got pain abdomen, suspect there may be duodenal ulcer. And it is usually after meal and frequently relieved by antacids or food. So these patients, when they are empty stomach, fasting little, they will start having pain abdomen. And food will relieve their, or antacid will relieve their pain. So it may occur between midnight and to 3 a.m. In gastric ulcer, pain pattern is different because ulcer is in the stomach, immediately food go there and it will irritate the ulcer and pain will start with the food. So discomfort precipitated by food, there is nausea. Since there is pain immediately after food, so he will develop anorexia. So he may develop weight loss. So elderly patients are less likely to have abdominal pain usually as presentation, rather they may present with ulcer bleeding and perforation, sometimes melena. So clinically, endoscopy detect the ulcer, and 30% of patients, less than 30% of patients will have ulceration in the stomach and duodenum. When we are thinking confirmed diagnosis that patient has got so long time history of burning epigastrium, still we do endoscopy and we will not find any ulcer. Only simply gastric hyperemia is there. Only red spots are there. No frank ulcer is there. So only less than 30% patients with typical symptom will be endoscopically proved to have duodenal ulcer or gastric ulcer. That's why we write diagnosis nowadays APD, that is acid peptic disease, because we are not confirmed that it is due to ulcer only. It is due to acid peptic disease. When it is endoscopically confirmed, then we can label them as a peptic ulcer disease. So clinically we already, so when pain is there and radiating to back, from epigastrium to back, chances are patient is going into perforation. So penetrating ulcer, when there, it may, chances are that he may perforate later on. So pain radiating back is a very dangerous sign or symptom. Sudden onset, severe pain and generalized pain later on. So epigastric pain suddenly happening at one go, and after 1 hour it radiates to whole abdomen and abdomen is tight. That means patient has developed peritonitis due to perforation. So this is common, very typical history. Tarry stool or coffee ground emesis. Vomiting, coffee ground color or dark black color stool. They are indicative of bleeding. So bleeding, perforation we see, perforation sudden happen, then there is guarding and rigidity there. Gastric outlet symptom. Previously when stomach, APD therapy was not very good. Only cimetidine was available and you have to take 5 times a day. Very high dose, 200 to 400 milligram every time, and at bedtime 2 tablets. And it was quite costly according to economic criteria at that time. It was available at 10 rupees when hardly 2000 rupees or 1500 rupees one person was earning. So single patient was consuming 5 tablets a day at 50 rupees per day. So you can see 1500 rupees per month therapy. So this was quite costly at that time, and people were using only antacids only. So this was relieving the pain only, but ulcer relief was less common. So continuous symptoms were there. Patients were developing usually ulceration, and they will go into gastric outlet obstruction. So patient will, they will be presenting pain worsening with meals. There will be nausea, vomiting, and undigested food. Say 2 दिन पहले उसने पनीर खाया, 2 दिन बाद में पनीर निकल रहा है, तो that was indication of gastric outlet. So this was common in those days. This was common in those days, about 30-40 years back. So you have to keep the history like that. Nowadays gastric outlet very rare, very less frequently we are finding. So physical examination of peptic ulcer, epigastric tenderness will be there, tachycardia and hypotension due to bleeding. So we have to take the BP pulse, we have to maintain chart, and vomiting or active GI blood loss may cause this thing, perforation. So we have to palpate the abdomen. Gastric outlet obstruction. So physically we may found succussion splash in the stomach distension, patient complaining I have fullness of stomach, and if he move the patient 2-3 times, आगे पीछे कहते हैं ना इसको, you will hear the some fluid is, sound is there, succussion splash. So complication is GI bleeding, we already discussed, perforation, gastric outlet obstruction. So what are the diagnostic? Gastroduodenoscopy, barium contrast was used previously, even double contrast barium meal examination was used that time. So these are procedures which were involving fluid contrast, drinking. Then we'll take the multiple X-rays of the stomach, then follow through, then you can take after 15 minutes, duodenal pictures will come, and they will give indirect indication about the ulcer formation. So we will say, oh, there is some collection of fluid here, dye here, and there is probably ulcer. But this has been replaced almost now by endoscopy, because we are doing direct visualization of the gastric and duodenal epithelium. So they are much more sensitive and specific and diagnostic. So this barium contrast has been almost abandoned in favor of endoscopy. Nowadays endoscopic ultrasound. So this is usually used for the gallbladder stone. So if gallbladder stone or sludge is there, and we have to see whether stone is there or no. Microstones or calculus are passing. So patient having attacks of pancreatitis, mild pancreatitis repeatedly, and USG is not showing anything, we can go for the endoscopic ultrasound. So another is Helicobacter H. pylori testing. So histological examination, we'll do endoscopy, take a piece of mucosa, and we'll send for the staining by GIMSA and do culture for H. pylori. We can go for serum antibodies, stool antigen test, we'll just see. Carbon-13 labeled radioactive carbon urea breath test. So we'll just now discuss. So if we are suspecting hypersecretory syndrome, we'll go for serum gastric elevation test and gastric provocative test by intravenous secretin. So we have already discussed evaluation by endoscopy. So H. pylori, we'll see this. So there are tests, invasive and non-invasive. This also, I think your book also has got this thing. Rapid urease test. So non-invasive, this is invasive by endoscopy or biopsy. We'll do this by a piece of the tissue, put it there. It's simple, fast and negative, but it can be falsely negative with recent use of PPI. So at least 5 days of PPI should be stopped, and then we should go for this test. Histopathological, so it requires processing and staining and provides histological information about the mucosa. Culture, it is time consuming, expensive also, and not much useful. So culture usually are not sending, but non-invasive test. So serology, antibody it will detect, So it is inexpensive, not much expensive, convenient. Urea breath test, it was previously very much used. So radio labeled urea given, and this is developing urease, which will produce ammonia, this H. pylori. So we'll put in the phenolphthalein containing jar, it will become pink. So ammonia will cause alkalinization of the medium. So it will give indication that H. pylori is present. Stool antigen, it is very inexpensive and very convenient. So differential diagnosis, you can see treatment, how to start. So main stage is eradication of H. pylori. So patient first we give usually PPI or H2 blockers. We'll just go through that. But patient is not improving, we can go for the H. pylori test. You try to prevent NSAID or other drug consumption and acid neutralizing inhibiting drugs. So treatment points are acid neutralizing or inhibitory drugs. So antacids is one of the medium. This was a H2 receptor blocker, PPI, sucralfate, treatment of H. pylori, and surgical therapy for complications. So antacid, previously we were prescribing, still we are on demand, we are prescribing to the patient. We know that it is not giving good results, but immediate relief is very good with them, because they do not help much in the ulcer, this one repair. So it will give immediate relief, because they will form a layer on the ulcer and their nerve endings which have gone bare due to ulcer formation, it will be relieved immediately. So most commonly used antacids are aluminum hydroxide and magnesium hydroxide. So aluminum is causing constipation, magnesium is causing diarrhea. So we give combination of both them, so that gastric, there is no diarrhea or constipation to such patients. Previously we are using ENO, still we are using sometime ENO that contains calcium carbonate, soda bicarbonate. So they are useful, but to a limited extent. H2 receptor blocker, all do you know. Ranitidine is most common drug. So another is famotidine and nizatidine. Cimetidine already out of fashion and very costly drug it was. And 4 times, 5 times you have to give, so it is not used nowadays. So this is H2 receptor blocker. Why? Because they got, their structure is homology with the histamine. So their action is also sometimes like antihistaminic drugs. So they can cause sedation also. So H2 receptor blockers very commonly, nowadays very cheaper. So this is dosings for Rentec, ranitidine or Stec. This 300 milligram HS or 150 milligram BD is commonly used. Proton pump inhibitors, the 4 or 5 types usually we are using. Omeprazole is simplest and cheapest, 20 milligram dose. Esomeprazole 20 or 40 milligram. Lansoprazole nowadays out of fashion, so nobody is prescribing. But rabeprazole and pantoprazole now are newer drugs. 40 milligram and rabeprazole is 20 milligram. So it takes around 2 to 5 days for gastric ulcer secretion to return to normal once these drugs have been discontinued. So after 2 to 5 days again patient will have recurrence of the symptoms. So this has to be continued for longer time. But there are some complications or side effects of these drugs. Though they are quite innocuous, we are prescribing them for 2, 3, 4, 5 years they are taking. PPI, omeprazole, they are once start, they will take for lifelong. But there have been questions nowadays to use such drugs for prolonged time, because in certain cases they have given some side effects like community acquired pneumonia. So they have blamed that PPI may be responsible for these. CKD, osteoporosis, deficiency of iron, vitamin B12 and magnesium, because they change the gastric milieu. So acid environment is reduced due to these drugs. So there is malabsorption of these vitamins and irons. So all these can get dementia, acute and chronic kidney disease. So they have been blamed. So in such patient, you should take a review of your drugs in such patients if there is problem. So sucralfate, another is cytoprotective agent, which is a complex sucrose salt in which hydroxyl group has been substituted by aluminum hydroxide and sulfate. So this will form a protective layer upon the ulcer. So it will immediately give relief, and patient will have prolonged effect of this drug, because they will remain for 24 hours or like that, and so further acid will not penetrate that part of the ulcer, and they will prevent further damage. So sucralfate has been found very useful. This compound is insoluble in water and become viscous paste within the stomach and duodenum, and binding primarily to site of active ulceration. So toxicity also are very rare with this drug, and should be avoided in CKD, because it contains aluminum. Usually 1 gram QID dose is there. So prostaglandin analogs, this misoprostol is quite useful but very rarely prescribed, and this drug is contraindicated in women who may be pregnant in near future. Another side effect of the sucralfate is black stool, constipation, and darkening of tongue. So patient should be beforehand warned that your stool may come black. Also your tongue may be black, as well as there may be some constipation which you have, because aluminum causing constipation. So they have to be explained beforehand, so that do not worry about this. Nowadays it is used as a anti-H. pylori drug, as a fourth drug. So H. pylori, when we are finding patient is not improving with simple these drugs, then we'll go for H. pylori testing. Sometime blindly we are starting the drug. So H. pylori treatment usually should be given for 2 weeks, 14 days. Lesser duration will cause recurrence. More chances are more recurrence is there. So H. pylori treatment should be given with 1 PPI and 2 antibiotics. We'll see there. And if not relief, then 1 PPI, 1 bismuth, and 2 antibiotics. So quadruple therapy is there. So 14 days has got safest efficacy, and usual agents are amoxicillin and clarithromycin. Based this one therapy is more useful. Tetracycline or levofloxacin can be given. Another drug is metronidazole and nitroimidazole. Sometimes fourth drug is bismuth compound, we just now told you. Therapy, triple therapy for 14 days, PPI with 2 antibiotic, quadruple therapy, I told you, add bismuth, 2 triple drug therapy. This is usually the triple therapy, quadruple bismuth based or non-bismuth based quadruple therapy. So multiple antibiotic, amoxicillin, I told you. In fourth drugs you can use levoflox or rifabutin, furazolidine or doxycycline or nitazoxanide. These can be used as a fourth drug. So once you eradicate H. pylori, sometime you have to retest it again. So stool antigen may be tested, because it is quite inexpensive and non-invasive. So clearance of H. pylori can be followed by that way. If again recurrence of H. pylori present still and patient symptom is still not improved, you can go for change of the drug, either 4 drugs, change the combination of drug, and you can again treat the patient with the same duration, 14 days. So JD syndrome, we told you high dose PPI therapy is to be given, and somatostatin analogs like octreotide is to be given subcutaneously. Systemic chemotherapy sometime for gastrinoma, streptozotocin, 5-FU or doxorubicin has been tried. And surgery, if there is tumor is found with the specific special secretive tool, then we can go for surgery also for permanent relief of the patient, because these are most of the time malignant also. So we have to treat them by surgery.